This is Dr. Sunstein of NSPC Brain and Spine Surgery, and this is...
And I'm Dr. Richard Obedian of Violent Spine and Sports.
Today we have a special guest.
Very special guest.
Very special guest.
In fact, I'm proud to introduce Christina Auriti.
Yep,
That's correct, Auriti? Good.
Body Movement Physical Therapy.
Body movement.
That's me.
And she has offices in both Great Neck and in Hicksville in my building.
We're in Great Neck.
Northern and Lakeville Road.
Oh my God, I used to have an office there.
Colonial Building.
No, I was right across the street. I was at 600. Yeah.
Yeah.
We're,
That's all the cool people are there.
we're all very, our orthopedic offices.
Associates
and
over there.
Our offices were on the ground floor. We used to have an MRI machine, but no longer.
That's a busy corner.
It's a hot corner.
Yeah.
Very close to our Lake Success office, so that's good to know.
Yeah.
But you've been a physical therapist for how long now?
15 years.
Wow. You don't look it.
I'm trying very hard not to.
Where did you begin your training? Where did you start out?
I went to NYIT
Okay.
right from high school. I got into the DPT program there.
So they still have that program?
Yeah, they still have it.
And it's a 4-year program or a 6-year program?
So I did it in 6 years, 3 undergrad, 3 graduate. If you get accepted into the program. If not, if you're just a regular transfer, you don't get accepted in, you apply into the grad program. It's like a regular bachelor's, 4 years, and then 3 years of PT school.
So you end up with a bachelor of
I have my doctorate.
A doctorate in physical therapy.
You are a doctorate?
We should actually be calling
Why
her
are we not
doctor.
calling her doctor?
We should be.
You can.
Lack of respect.
That's amazing. How many doctors of physical therapy are
They're
running
all
around?
doctors
A
of
lot.
physical therapy.
They're all
From
doctors?
2000 on.
Yes, pretty much.
Why is that?
Because they've expanded their training now, and
Well, now I think part of it has to do with direct access.
right.
right,
So there's a trend now that patients, used to be that you needed a prescription to go to physical therapy.
Correct.
But now in some states, including New York, you have direct access to a physical therapist. So let's say you just know that you need some physical therapy for your knee or for your back.
You don't have to write a prescription to get them
You can go straight to the physical therapist. Now some physical therapists like that and some don't like it as much because, after a while, if they're not getting better, you don't want to miss something.
But I just don't understand, you go for the undergraduate initially, right out of high school, and then the 3 extra years gives you a doctorate in physical therapy?
That extra, I guess it was like another clinical rotation. So it's another class differential diagnosis to make sure that everything we're treating is musculoskeletal and not systemic.
Right, you don't want to miss a cancer.
Right.
So what was your training like?
So I liked orthopedics. I always liked it. So I did 2 or 3 rotations there. I did a rotation in a hospital.
Well, let's face it, orthopedics is the cooler specialty between neurosurgery and orthopedics.
Well, I'm a
think
little
that
partial to
usually-
it, but
I
I'm not going to get in
neurosurgery
between the
is
spine
kind of
bros.
like the gold standard of
like wisdom, like, you don't have to be a neurosurgeon to know how to
brain
do
surgeon.
this.
I don't see you have to be an orthopedic surgeon. I never hear that around.
Yeah.
I'm going to side with him on that one, but I do.
That's true.
I am a little partial to orthopedics.
Lay people think that.
But the problem is a lot of lay people think when they have back pain, they go to orthopedics, not even thinking of neurosurgeons. That's the problem.
Because usually it's not always neurological.
Well, that's true.
They go to the neurosurgeon if they're having numbness or weakness or other kinds of symptoms that would, and a lot of times they'll go to the neurologist before they see the neurosurgeon.
It's amazing who they go to before they even come see us.
They go to their family practice doc.
They go to their cousin.
They just go to physical therapy.
Or they go to, physical therapists, I mean, look, we send patients tons of physical therapy for many years, and it's very important, but, I don't get a lot of referrals from physical therapists in general.
So I guess some of it could be like if you're going down the list, right? So you send to the ortho, then you send to the neuro, and then, if the neuro thinks that a neurosurgeon is going to require the patient to be seen, then that might come from the neuro.
Right.
It's not my first, stop to say, hey, you know what, I think you need to go to a neurosurgeon. The problem is because I think some of the patients have a bad rep with neurosurgery. They think they have to have surgery, but
Orthopedics maybe is less scary to them?
that's what
Interesting.
It sounds like from
I
what I gather.
Definitely less scary.
Yeah, because they think about neurosurgery, they think of paralysis. That's the first thing.
Right, or like they have to operate on my spinal
paralyzed?
cord.
Did they ever ask you if you're going to be paralyzed from your surgery?
It's always in the back of everybody's mind when they're having any kind of spinal operation. It's seldom voiced, but it's always there. So I usually try to allay their fears and say, we're below the spinal cord, especially in the lower back, and paralysis is really not, that's what people worry about.
Yeah.
But it's not really what realistically.
That's usually not in play. But I mean, as you continue on, you were telling us about your training and your background.
What's interesting is that you decided in high school
Yes.
you wanted to be a physical
So initially I said athletic training because I was like always very athletic. I like sports. I like
Were you an athlete in high school?
that stuff. I was.
What'd you play?
I played soccer and softball.
Oh, nice. I played soccer. Yeah. What'd you play? You were a swimmer.
I was in the swim team.
Weren't you a baseball pitcher too?
I did that for a while. I did, I dabbled in a lot of sports. I played a lot of tennis. I used to play. I mean, I was really
You're still a decent tennis player.
I used to play a lot of stuff until my knee.
Did you move on to pickleball now, like everybody else?
I played it once. I don't know. I mean, I guess because of I have a problem with my knee, so I can't do some of those things.
It's not so bad.
Well, you haven't come to see me, so therefore you still have a problem.
You need to start seeing Christina.
Maybe I do.
Your problem is that you're too friendly with the chiropractors, so they don't really take care of knees. And
Well, the thing about chiropractors,
they're good.
They do a lot of things.
Now you actually work with chiropractors too, right?
Yeah.
So you have a good relationship with chiropractors. You guys work in concert with each other, which I think is a good thing.
Honestly, I think it's nice to have another practitioner in there to bounce your ideas off of. And I'll be the first one to sit here and tell you I don't know everything. And sometimes an extra set of hands, an extra set of eyes to kind of say, hey, you know what? This patient might actually have something going on here.
Kind of like our relationship. It's nice to have an extra pair of eyes and hands, especially in the operating room.
I agree.
It's always good to bounce ideas off and not be
texting each other.
overconfident and say, what do you think? And there's different approaches. What should we do?
Yeah, we work together. I feel like some people have this I only go to PT or I only go to chiro, but sometimes the combination of the two actually is really what helps.
Right.
So you feel right. That's the whole thing. Synergistic. You don't feel like you're butting heads with the chiropractors. Don't go to a chiropractor. Only stay with.
They're not the enemy.
No.
Can't we all be friends?
I think that's the way to approach all relationships in medicine. Frankly.
I don't see. I haven't had a problem with it in the 10 years that I've been doing it. It's only really helped.
Do you have your favorite chiropractors you like to send to, or you don't have to mention
I'm a little impartial to the one that's in my office. Tom, he's wonderful. He's a great guy.
I met him. You have a chiropractor in your office?
No, I don't have one in my office.
Well,
but Tom will come to Hicksville sometimes.
Okay, no, I understand that.
Yep.
Right.
So continue on. Tell us more about your, what you led you to work in, where you are now.
So I finished school and I was like, you know what? I am going to go straight into ortho. So that's what I did. And I did my last rotation at Franklin Hospital, which is now Long Island Jewish Valley Stream.
Good old Franklin Hospital.
Starting their ortho.
We used to go to Franklin Hospital.
We used to do a lot of stuff at Franklin Hospital.
Well, you didn't want to go to Franklin Hospital at one point.
I liked Franklin. Coffee shop was very good, actually, at the time when it was there.
It was privately owned. And
that was
very nice.
Good thing. We used to get a lot also. That was a busy hospital. That was a very busy hospital.
Well, it wasn't at one point, and then Northwell took it over. It was North Shore LIJ, and it was just Franklin Hospital. And then it got a little bit better once Northwell had their hands in there, and then they started their ortho program. And that's when I started. That's when I did my clinical. It was they were doing spine was there, joints were there.
A lot of spine was being done there.
A lot of joints were being done there too. It was a busy.
So
wasn't that
the old ISK?
ISK.
Yeah, the ISK split up.
Yeah, Latuga was in there at one point.
And came to Franklin.
Yeah, I mean, it was...
Yeah.
And then, so I always was like, you know what, I kind of liked that because I was learning more medicine in general.
And that was in an inpatient setting.
That was inpatient. So it's very different from ortho, So I kind of liked having the knowledge base between both being inpatient and outpatient. I am truly not an inpatient therapist. I don't like doing it, but I enjoyed it for understanding the knowledge of medicine that I would never get working in the outpatient setting, honestly.
Well, you lose a lot of your skills just doing inpatient because what you're basically doing is you're taking people for walks.
Getting them out of bed.
It's important to stand up, walk, and sit down.
Right. Patient walk 50 feet today.
Yeah.
I tell you one thing, though, the notes are quite extensive, though, for just getting them out of bed and walking them.
Yeah, well, you have to.
They have,
justify all that with the insurance companies.
Yeah, no, there's definitely a lot of extensive, almost
Notes.
unnecessary things in the notes, but whatever. That's the
You
new
need
world.
it
That's the
now.
new world we live in.
You need it now.
Yeah.
So let me ask. So you deal with, we'll since we're the spine bros, we'll focus on spine problems. So if somebody comes into your office with, let's say, lower back pain. There are different schools of thought, right? Like
McKenzie
there's
extension,
McKenzie extension,
flexion,
and so what's your feeling on that? I mean, my feeling is always like, well, whatever works for you.
Well, I mean, do you
And
have to
different
know what the
physical
problem is, though, first? I mean, do you have to, like, somebody walks in the office, they say,
Not necessarily if I have direct access. I don't know what the problem is.
Well, actually, can you order an MRI?
No.
So you have
Can't
direct
order
access, but you
MRI,
can't order any imaging
can't
test.
order any imaging. So I really
you're kind
go
of at a
based off
disadvantage.
of what my hands feel, what the patient tells me, and how they present.
Who's
Because
usually sending you I mean, has the patient just, like, finding out by word about
some
your
people come
advertising.
in, some people walk in, like,
Friend of a
in
friend.
Great Neck, I'm in an office building, right? So, like, unless you see my advertisement on social media, chances are you don't know who I am.
But then how do you get your patients generally? Mainly.
In general, word of mouth, previous patients, which is always your best referral source. You get attorneys, you have different
Physicians.
orthos.
Okay, so you have a wide range of referrals.
Right. But, like, sometimes if I just get a prescription from a doctor that says a low back pain, I still have to assess the patient anyway. They're not telling me anything.
So how do you assess, like, so you assess them
So
for
I
problem.
usually go based off of, like, a movement, right? So, like, what are you doing that hurts? What are you doing that doesn't hurt? When do you feel it? How intense do you feel it? What are you feeling? Is it localized to your low back? Is it radiating down your leg? Is it going past your knee into your foot? And then I go based off of what positions make them feel better.
Right, so extension is usually more muscular, flexion's more disc related.
Right.
Do you
exactly.
do you examine their strength? Grade them,
Yes.
everything
So,
like that.
if a patient can get up from the chair, they're 3+, right? So I don't necessarily have to really do all this, like, manual muscle testing. I operate more on a functionality scale because that's where you're going to be at the end of the day, right? I don't need to know that you have a 5 out of 5 in your rectus femoris. I don't care about that.
Right,
I care
doesn't
about if you could go up and down the stairs,
Okay.
right?
She's not looking to diagnose which nerve is being affected.
No. I just want to know, like, if you examine for, like, foot drops, things like that.
Well, yeah, of course you're going to see.
because they're going to see that in
Right.
the
If the
functionality
patient
of
has
the
a foot
patient.
drop, that's a direct referral to
And she'll send it to
probably a neurosurgeon.
Yeah, the neurosurgeon. Why is that?
or an orthopedic spine surgeon,
Or them, either one, whoever can get in first at that
spine
point.
surgeon.
Oh, we get them in very quick.
All right, good.
Very quick.
That's true. So anyway, so you assess. Is it more muscular? Is it more disc related?
Right,
And what's your thought on, like, let's say it's just back pain and it's more muscular. How do you attack that problem?
Well, the problem is half the world is sitting for a prolonged amount of time.
Sure.
Right? Think about
And when you're
people's
sitting, you're using all your
jobs,
back muscles.
right? Like, what are they just sitting at a computer
Your
for
back's not
hours and
getting a
hours
break.
and hours? So their hip flexors are tight, their hamstrings are tight, their glutes are weak, their core is weak, their shoulders are forward, their head is forward, their spine is, like, completely out of alignment. Just fixing posture actually really can help.
Yeah.
So how do you do that?
I tell them to pay attention to what they're doing. Look in the mirror,
Speaking
watch
of
how you're
posture, better
sitting.
sit up straight.
Yep. Sit up.
Well, your mother was always right.
Yes.
But still, I mean, so what do you do to those patients to make them feel better?
So I usually
pain.
start with, like, a little stretching, right? Because, like I said, everyone is sitting in a 90-90 position. Chances are hamstring, quad, hip flexors, piriformis, they're all tight, right? So when you have tight posterior chain muscles, what are they doing? They're pulling down on that pelvis.
Especially as people get older. When
yeah,
you were a kid, you never stretched. Now,
Well, now it's essential. It's the
No
first
one
thing I
ever
do is
stretched, no one
stretch. When I
drank
get out
water.
of bed,
Now-
I have to stretch.
now we're all stretching and drinking water all the
Walking around
time.
with Stanleys everywhere.
I definitely need to stretch.
Stretching is
so
really
I think
important.
part of that actually really just will relieve some of the misalignment in the spine, right? Just from a muscular standpoint.
Yeah, tight hamstrings are really important.
I'll do massage. I don't love doing it because I feel like physical therapy, you should be doing physical things. So I'll do some sort of therapeutic massage, but I'm an exercise girl.
So you get them on a
Everyone's gotta
treadmill
be
or on a
moving.
bike,
Gotta
get
be
them
moving.
moving.
Got to be
Keep
doing
moving.
things, strengthening those muscles. A lot of times you're in pain because the muscle is too tight and too weak.
Yeah.
Okay,
Yeah.
so you.
No, I think a lot of back pain is muscle fatigue.
Yeah,
Because
just endurance.
at the end of the day, they feel much more tired. You've been using those muscles all day, like you said. You've been sitting all day.
It takes
exercising.
muscle
You're out of shape.
firing to sit up straight. It's much easier to sit slouched. You have gravity on your side.
Right.
So many people come in with complaints of pain in their back where the muscles attach to the pelvis, like right at that junction where the ligaments of the muscle, of the paraspinal muscles attach to the pelvis, right there in the posterior. And then, people get all kinds of treatments. They'll get SI,
SI joint injections.
When it's not the SI joint,
it's just in that region.
Although I find that problem is sometimes hard to diagnose
SI joint
properly.
It mimics a lot of other things.
A lot of things, and the pain people get as you sit for long periods of time, you get pain in your buttock that goes down your leg. It doesn't necessarily mean it's a disc herniation. It could be just a piriformis muscle. Do you think that sitting for like over an hour, what happens to the piriformis muscle, you think?
It's completely stretched depending on which way you're sitting, how you're sitting, and it's compressed.
And that compresses
and then you have the sciatic nerve that's right over there. So
that's why people get that, because I get that when I drive for an hour.
Syndrome?
I do get that. I drive in the city into the city every day, and by 1 hour, it's the same recurrent time.
So you got a real pain in your butt.
So I got a real pain in my butt.
Here you thought it was him. Now you have a real one.
And it only gets better when you stand. That's the only way to relieve it. And you can't stand when you're driving.
How do you stretch your piriformis?
That's a good question. How do you do that?
Sit in figure 4.
Figure 4. You take the leg and put it the opposite side, right?
Lean forward.
And lean forward. That's it.
So you take the leg. Okay, do it again.
Figure 4, right? Ankle over your knee.
Okay, ankle over your knee.
Lean forward.
Because this is my right one, so I take my right leg, put it over my knee, and then I flex forward like that.
Yeah, you should feel. I feel it.
The problem is I can't take the foot off the gas pedal.
No,
not when you're driving. You don't do it. You don't stretch right while you drive you out of your mind.
I can't do that.
You driving a self-driving Tesla, or are you driving your?
I really, have not gotten to that point where the self-driving car. But
it is a little creepy, though.
But you wish
you have one.
No.
But you wish you could at that point stretch it out properly, and you can't. So people,
But if you stretch beforehand or after,
I don't know if that would help.
That.
Maybe that would help.
There's too much traffic in New York.
So you think that maybe doing that stretch before driving would be very
definitely.
helpful?
And even before, if you guys are standing while you're operating, I'm sure you feel the same thing, right?
Do you stretch before you operate?
I do. I actually, really? I do. I really do. Huh. I do at home a lot.
Do you put on like Jane Fonda and go through?
No, I'm not. That's a little passe, but
that's very 80s.
I don't use that video anymore. The one that got her all that fame. But I
think she's still making money off of that video.
I'm sure somebody has to be buying it.
Good video. That was the craze.
So low back pain, you're more into, instead of stimulation and massage, you're more into
everybody likes it.
Movement.
Yes, and it also depends on the patient. Depends on the age of the patient. Certain patients are capable of doing certain things, like an 85-year-old that's going to complain of low back pain. So we're going to give her the heat. We're going to give her the stim. She's going to get a little massage. She's going to do some basic, simple exercises. A little stretch goes a long way with someone like that.
Okay.
The younger generation, that is, you have that highly athletic patient that wants to go back to exercising and they can't because they have this electric pain down their leg. Do they have the patience to go through physical therapy sometimes? No.
Well, I think people sometimes are in too much pain to participate in physical therapy.
Well, that too. So this is kind of like where I'm getting at, right? So if you're being consistent 2 to 3 weeks and you see absolutely no change, then my referral would be to neuro, some sort of pain management for an injection of some sort, so that
we get some imaging.
Take away. Well, I can't give
but
imaging.
You can refer to the doctor that can.
Right, exactly. And before they do an injection, you're going to get imaging anyway. I would imagine, right? Okay. So, something like that.
That's kind of the standard of care, although sometimes we don't see that.
I have also, patients with neck pain. Okay, this is another one. Which the patient have a little bit of, degenerative disease of their spine. They have some osteophyte. That maybe the osteophyte is compressing the foramen, the nerve on that side where their neck pain is, but it doesn't really go down the arm. Mm-hmm. So those patients are difficult patients to treat because, it's not so cut and dry why they have the neck pain. Is it due to the osteophyte? Is it due to just pure muscular? Mm-hmm. What techniques do you use? And also, in patients who have some cord impingement, spinal cord impingement, but they're not ready for surgery. They just, maybe have had 2 weeks of symptoms. We want to treat them conservatively. Do you ever use techniques like distraction, things like that? How do you treat these people next?
So I love treating the cervical spine.
Great.
And shoulders. They're my favorite to treat.
Interesting.
Yeah. I mean, shoulders are fun.
That?
I did not know that was her favorite.
Yeah.
Okay.
I know she's had a lot of success in my patients with necks and shoulders, but also lower backs and other body parts too.
So I like to treat the spine, the cervical spine. I'm a big OA release girl. I don't like to just massage the spine, the cervical spine. I feel like it just doesn't do much. Yes, it gets its point across.
What does that mean, OA release girl?
Occipital atlanto release, right? So you have all the muscles that start or insert at the base of your occiput, right? Everything's tight. They insert onto the shoulder, into the levator, scalenes, all that stuff.
All those muscles that we just cut through and never...
That we just
all my blood, sweat, and tears in my hands, you just slice right through
that muscle
them.
we just went through? It's just a...
That looks like it could be the omohyoid.
That's from the front.
That's okay.
But yes.
So I'll do a release on
back,
a lot of those. And that'll actually take away a lot of pain. And even migraines. I love treating migraines. But for some reason, doctors don't really...
I don't know. It was a thing
PT.
to describe physical therapy for a migraine headache.
Oh, yeah. Here you go. Learn something new.
How about craniofacial? Like massive
TMJ.
pain, TMJ?
TMJ, yeah. I mean, I don't do any internal TMJ.
What is internal TMJ?
Like in your mouth.
You put your finger in their mouth.
Yeah,
Oh, no, that's no mucous memmembraries.
No. I
It's not close to that barrier, yes.
But I'm saying, but if somebody comes in with pain and they're...
But some TMJ specialists will put their hand in the mouth
Oh,
and
yeah.
manipulate the jaw.
You could release it from there.
All right, interesting.
There
are some
very,
physical
very painful, but you can do it.
There's some physical therapists who specialize in TMJ.
in TMJ.
Terrible pain.
I mean, half the time your masseter is just completely in spasm.
Is it from just a lot of stress, you think, that they're masseter? Clenching too much, grinding.
Clenching and misalignments.
A lot of things are stress related.
Oh, yeah.
And that case that you bring up with the neck and the osteophyte, it's a common thing. I'll get an X-ray and it'll show an osteophyte, and I'll say to the patient, this just didn't happen last week. You've had this for a long time, but your pain just started. So what did you do? And a lot of times they can't think of anything specific, or and then later they'll say, well, I may have twisted my neck. I was shoveling some snow, or something happened. And I think that's more muscular. I think the osteophyte is just kind of it's there, but it's been there. But it's not the pain. The question is, what's the pain generate?
Right, and then why does it last so long? That's the other thing.
Muscle pain is a hard thing to get rid of.
It takes...
because you probably partially tear some of that muscle insertion, and it gets re-irritated every time you twist it or turn it a certain way. That's why sometimes immobilize them in a soft collar for a short period of time is helpful. Although you want to minimize that to get their function back and get them moving. So that's why we have Christina.
Yeah, that's that whole thing. So I really am interested to know some of the things you do to help them.
Yeah, I do. I'll do a little cervical traction manually, which I like to do. A lot of patients like that. It feels good.
Yeah.
Kind of opening up that
especially
space.
a person
There's
has
not a lot of space to begin with. So when you put something that should not be there, like an osteophyte that's been growing.
Would you consider doing any gentle distraction on any patient with a herniated disc in the neck? Let's say they have pain down the arm.
Manually, yes, because I can control
manually,
that.
Because you control what you're doing. Okay.
Yeah.
She's not doing a manipulation like a chiropractor.
Like a chiropractor. But even a chiropractor,
I do like a little bit of distraction there. I do my own little funky cervical thing. I enjoy treating them. Migraines, I have cured, not to give myself a pat on the back, but people that have been on migraine medicine for years and years and years,
What's the secret to cure a migraine headache?
Cervicogenic headache.
Cervicogenic. So is that really migraine, or is it? Because I always thought migraine was more like a contraction of a blood vessel, or
that's
vascular migraine. That's
what's causing
vascular migraine.
I always thought migraines, had a specific criteria, so many times per month.
They have an aura, light sensitivity.
They can have a complex type migraine, but I mean, a lot of people get pain in their head from their neck.
Some of it comes from.
So you're saying the etiology is muscles, or some
Some
migraines?
of it could be,
Those muscles
whatever aura
attached to
they
the
get.
occiput. They go all the way up to the occiput, those muscles from the cervical posterior.
Oh, yeah. All your muscles in the skull. I mean, that's like a...
Is that more of a tension headache, or is that more of a migraine headache?
Could be both.
Could be both.
What differentiates a migraine?
It could be a tension headache that evolves into
a migraine.
What is a migraine headache to you? Like, how do you
I get
define
them.
that?
They're if
You get migraines yourself?
I do.
Oh,
They're
that's a bad
terrible.
thing.
Are they mostly?
Some of them could be hormonal.
Okay,
You know,
that's
especially
true.
for women
Sure.
during their cycle. And unfortunately, there's not much I could actually really do for that. But I could help it
symptoms.
and stop it from going to this crazy severe
Stop it
migraine
from
where
spreading worse.
you're nauseous and vomiting and like crazy light sensitivity. So like if I could minimize the level of what it is, then yeah, sure.
How do you treat yourself?
I don't. I'm like trying to like pull my neck.
Try to-
And my husband's like, "What are you doing?" I'm like,
Migraine.
If I ask you to do it, it's just this.
Yeah.
So you basically you like treating cervical spine, you know, because we see a lot of patients with just neck pain, you know, and the question is like, you know, is the origin from a pinched nerve?
Well, is the shoulder pain from the neck? Is it, that's
Well,
always
that's
a
the other
question.
thing when yeah.
But there was an
an
orthopedic surgeon.
orthopedic surgeon who's retired now who coined the schneck, basically.
That's what he called
shoulder, neck, and the problem sometimes is the shoulder, not the neck. You know, it's a reverse
And
impingement.
I'm posture. I'm a big posture girl. You could correct a lot of stuff with just putting yourself in good posture, especially in the shoulder.
Really?
For the shoulders, posture's
How do
important
you
too?
do that?
How do you do that?
So if you come into like forward flexion of the shoulder, right?
Right.
You try and go forward flexion of the arm. I can't lift my arm up physically anymore, right? If I come into good posture, I get another
10 degrees.
10 to 15 degrees
Yeah.
of shoulder flexion, right? So just think about that, right? If you're in this rounded shoulder, constantly doing overhead things, what's going to happen? You're going to start to get tendonitis and the supraspinatus and biceps.
I see what you're saying.
And
So in other words, if
all
you-
that stuff. So just fixing your posture
Gives
so
you more
that
range
you're
of motion
having
of your
better
arm.
mechanics.
Right.
You know,
That makes sense.
Yeah.
opening up this chest wall, right? Everyone's always forward shoulder.
Everyone's on
Forward
their phone.
shoulder,
Yeah.
forward neck, right? So this is the position that everyone's in on the computer for 8 hours a day.
Yeah.
Yeah, it's only a matter of time until they're going to start to feel something.
Right, but it's not the spine necessarily. You know what I mean? That's the whole
No,
thing.
it may not be like a disc dysfunction, but muscularly we have to fix what's going on there.
Is there a way you could differentiate between just muscle and posture versus just a disc? Like, is there something that tells
If I'm giving you like a chin tuck and you start to feel some of that going down to the arm, I think that's
you
obviously
think more
indicative
spine
of
or origin
spine
of the
versus
problem.
just
When they have
muscles.
more radiation, it's more disc related, or they have
And
other
thoracic
symptoms.
outlet is another hidden thing that not a lot of people know about.
Yeah, it's a real problem.
Oh yeah, I have it. My right shoulder.
A lot of baseball players get it.
Yeah.
Yep.
It's hard
Tightness
to-
in the pec. You have like, your shoulder mechanics again are big with that. You know, you feel that sometimes I'll get that heat radiating down.
Sometimes
into
people have an
here.
extra rib.
Yeah.
Which,
I had a
you know,
patient. She removed
She
her rib.
had to remove a rib. Yeah.
I mean, she had like, her hand was like white, so she had like it was an
real
emergency.
vascular
It was
symptoms.
causing
Correct.
occlusion. Yeah,
It
you got to see for that. You got to see a vascular.
That's a vascular surgeon, right? But I don't know who removes the rib.
Whoever it
The
was.
vascular surgeons will do it. There were vascular surgeons at Winthrop will do it,
They'll
or
take
NYU.
care of the rib. Yeah.
They go. Some of the baseball players have gone to
But
Columbia.
like something like that, I would refer to my chiro because I'm
They
not
treat-
adjusting any ribs. So if your first rib is out, sometimes just putting it back in place will actually open up that space so you can avoid losing a rib.
Yeah.
but it's probably going to go back.
Not always, sometimes.
You
Well, then you have to teach them to say, hey, you have to have good posture. You have to make sure you're doing this. Watch how you're lifting
Right,
at
because
the
they've always
gym.
had
Watch how
that
you're
cervical
sitting.
rib. So
Why now?
why now?
I know. That's my big question too. all the time.
Why now? Is because they're always like they're getting older now. They're starting to hunch forward, or it's interesting.
That's
So
why
I shoveled the other day, right? We had
You
crazy
shoveled.
snow. I shoveled.
Shoveling's not good for you.
It's not, but if you shovel
an
the right
exercise.
way, it's actually
It's an
very good.
exercise, but it tends to cause injury.
If you do it
And
the
not
wrong
not
way,
not
yeah.
just orthopedic or spinal injuries, but also cardiac injuries.
Oh yeah.
That too.
Because somebody's not used to working out, and they get up in the morning, it's freezing cold, go outside,
That's right.
Or
shovel,
it's
and
really-
I always tell
Something-
patients to avoid shoveling.
the next thing you know,
Because I see patients
You're
all the
the
time with
even-
complaints still. I was shoveling snow and now I'm in,
Because
now
you got to
I'm in
bend on your
agony.
knees.
Well,
gotta come
that's
into a
very
squat.
important.
part of the problem is that the kids today, they don't want to shovel. Like when I was a kid, we would make money going around
All
neighbor
the
to
time.
neighbor. Nobody knocks on my door saying,
Not
I
a
want to
single
shovel.
person.
Anybody knock on your door and say, hey,
No. They're
20
afraid
bucks to shovel
They're
your-
afraid to walk on your property because they think you're going to get shot.
No, it's Long Island. Nobody shoots you in
Oh
Long
yeah,
Island.
well there's
White picket fence, Glen Head.
there's a lot of gun ranges
that.
around here, man.
Okay, come on.
I see a lot of people.
You've been on. I don't know what's going on in your Instagram feed, but
I
you got
watch
some
the news.
Been around the
issues.
block before.
They don't shoot you in Long Island.
I don't watch
for shoveling your
Instagram.
snow.
Well, somebody goes on their property, they
Come
get,
on.
they get uptight.
That's not the reason.
They get up to
Listen,
I think this generation doesn't want to work.
well, I
No,
think
they
that's.
don't.
They don't want to work.
I read somewhere this morning where nobody's going to work now. We're just gonna get a basic
Robot. I saw a robot
Robots are
shoveling
going to do
snow.
everything at this point. We're not
Yeah.
going to have to worry about anything.
Do you guys use robotics in your surgeries?
No, we're old fashioned.
Well, you know,
figured, but-
robotics is kind of it hasn't really hit
come
spine
to
surgery
spine
yet.
surgery yet.
There was a robot from Israel about 15 years ago that was out there, and I actually went and got trained on it, but it really wasn't ready for prime
I mean,
time yet.
like where surgery where you sit in the corner of the operating room and
the urologist, the Da Vinci.
right, like the Da Vinci robot, where these general surgeons and the urologists they control the instruments, but they're usually working within a cavity where they can actually the problem is you can't like blow up the spine to do that kind of thing. You have it's a different tension, a different exposure.
I know joints. They're big with.
They're using robot. I mean, they like
Yep.
some surgeons are using the robot to help them make their cuts.
Get a better angle
Knees,
on like
people
In
use
total
yeah,
knees, yeah,
and hips. Yep.
and hips also.
Well, here that's
and-
a good
and-
question actually. Yeah.
And there's software now for spine in terms of putting your pedicle screws and how to
Right, the
aim
screws.
aim it perfectly.
But I feel like some of that you need to like finesse a little bit. Like
You know, when I was
There's finesse. What we do is
there
finesse.
is. When I was a fellow at special surgery, one surgeon was using this. He was trying out this new system called the Stealth system that Medtronic had put out, and it was accurate, but it wasn't that accurate. You still had to know what you were doing.
Yeah, of course.
And there was another surgeon who
So it's not like Tesla yet.
not like
Where the
Tesla.
kid just drive?
Yeah, and so there was another surgeon who was a big scoliosis doctor, Dr. Bawachi, and he did not believe in stealth whatsoever. And he said, "We're the Marines. We're going to really. You got to see it, and you got to do it yourself. You got to know what you're doing. You got to feel it.
You got to feel everything, and
Yeah.
the thing is, the different robotic type surgeries, you don't have the nerves in play. There's spinal cord. That's what we have, and that's the difference. So
And I saw it a few times. The stealth was telling you to go a certain way, and it was clearly wrong.
Well,
and it was off by a few millimeters,
why
and you
it's
could
good
get
to have feel.
you got to know what you're doing. Even you can't put all your faith in technology. Is my point.
I get it.
And Dr. Sonstein has almost 30 years of wealth of experience doing this. He's got good hands. And we've seen it so many times that we know where to put those screws in. That really that's not patients are very afraid of the screws.
Of course.
It's so funny. They're more afraid of the screws and the fusion than anything.
And that's
the
probably
laminectomy part, which is actually the harder, more important part of the
Chopping the bone
surgery.
out?
I agree. The harder part is getting a good decompression and
That's
avoiding a
the
spinal fluid leak.
void.
And the easy part, the fun part, is the orthopedic part, putting in the hardware.
The hardware is usually
carpentry of
more
the human body.
And they're all worried about the hardware.
right because the thing is the hardware is more. In many ways, it's more prophylactic for the patient in the future to prevent the problem from coming back and preventing further problems.
Now,
right. No, I was just going to say that that's the thing, and what really is important for them to understand is that the main part of the surgery for us most of the time is to decompress them, and that's the art really of the surgery.
Sure.
Putting in screws. Yeah, I mean,
You could teach a robot to do that.
you could do to anybody to do screws. You do enough of them to know where the landmarks are and all
Yeah.
that other stuff. Anyway, going on with physical therapy.
So does your physical therapy change post-operatively, whether somebody has a fusion with hardware or no hardware? Does that make any difference?
That's a very good question.
Yes. Obviously, I'm not giving many extension exercises just because they don't have the flexibility.
Yeah, how do you deal with
Like it's
post-operative
very
patients?
rigid. You know what I mean? Like, I'm not going to be putting someone into an extension position with a fusion. It's just
What do you do with them when you see them after the surgery? Like a big incision in their back. What do you do?
I just make sure that the incision looks good.
Oh, good.
Because they don't see it.
She wants to make sure there's no infection.
Right.
Yep.
You
redness,
can't
there's no-
see what it looks like back there. So, and in general, when I treat anyone low back and anywhere in the back, I'm always looking, even for like funky looking, like skin tags or moles or anything like that. Like I sent a patient to a dermatologist. She ended up having skin cancer because I just didn't like the way it looked. So that is part of your differential diagnosis.
That's impressive.
You are a primary doctor.
Yeah, some of my friends, yeah.
Because you're really screening
That's like
out
that
the
episode
back.
of Seinfeld when he was dating a dermatologist and she said, "You don't save any lives."
Yeah.
And he goes, "Of course I do. I
Well,
skin cancer."
Exactly.
You know, she just saved somebody's life and discovered a skin cancer.
So-
Amazing.
But yeah,
feel good about
that's
that.
my big thing. Like looking at the incision, making sure that it looks good because that can go south very quickly.
When do you like to see patients generally post-operatively after? I mean, when do you think is appropriate for patients to really start getting physical
I guess
therapy?
it kind of depends on the procedure that they're getting, right?
Just like a regular laminectomy fusion.
We usually don't send them for a few weeks after. Let them
say,
recover a little
2-3
bit.
weeks, I would
about a month
imagine.
later.
Let that.
If they're in too
let
much
everything-
discomfort, to really get into working with you.
Right, and then like you're not going to. They're going to be doing basic, simple exercises that they could probably do at home, which they probably don't.
Spine surgery is very destabilizing in terms of their musculature post-operatively because you basically you strip away the muscles, to get to do this procedure. Those muscles are important for posture and for stability.
Right. So the endurance in those muscles are just going to be weak just because of the incision.
That's why you want patients to
Strength
be
in
in
general.
top shape before you operate even.
Right.
The best
Well,
shape you can be, you have a better recovery afterwards
that's
is
the
my
other-
experience.
You like to see patients before surgery
I do.
too.
I like a little prehab.
Prehab, it's nice.
That's a very good idea. I think the
Yeah.
And
patients.
then they become comfortable with you.
Right.
Well, most insurance companies require a course of physical therapy or non-operative
Absolutely.
treatment for at least 4 to 6 weeks before you consider
Yeah.
running to the knife. Because let's face it, a lot of these patients get better. They don't all need operations.
That's why we always try for physical therapy.
Physical therapy is a key part of their
Conservative management.
recovery, and if you can get them better without,
I usually tell
usually
patients.
surgery is the last option. You try everything else first.
Particularly cervical radiculopathy. A lot of patients really do get better over time.
Even people who've had weakness have gotten better. I've seen that.
100%. I've had a lot of patients that come in, you really think they're going to need surgery, and you say, well, let's try the physical therapy first. And
Yeah, and it's
They
and
get
it's some of
better
it is
over-
the patient responsibility too. Like you can be a great surgeon, you could be a great PT, but if the patient is not going to be compliant, that's the other problem.
what are some of the essential things you need to set up a very good physical therapy, center? What are the tools you really need?
So, I mean, the standard has changed, right? So it's typical physical therapy back years ago were electric stimulation, heat, massage, little glute bridges for low back pain, and, you're out the door. Now there's a lot of different things. Hip mobility. I'm a big fan of hip mobility because I think a lot of that could be fixed when you have a spine, like low back issue. I'm a manual girl. I'm an exercise girl. I don't need all these fancy tools. However, cool thing that we have in my Great Neck office is a shockwave machine.
What is that?
It's like high frequency, like sound waves. It's like a very, very big ultrasound.
So what does that do for the patient?
You use that for plantar
Promotes healing.
fasciitis or use that
Yep,
for...
I use it for any sort of tendonitis. It works great with tendonitis. I had a little plantar fasciitis from wearing bad shoes during the winter. And
Right.
2 sessions, and I'm completely fine.
Ah,
And it just breaks up the inflammation? Like
It'll send
breaks
these
up the tension?
shock waves, the sound waves. It's like, ultrasound
Yeah.
back in the day. It's
Sure.
like mega ultrasound. So it's really getting to the bone. It's painful. I'm not going to lie. It's
painful when they're getting it, but then
Painful when you're getting
they
it.
feel better afterwards.
yeah.
so what are the things that we would send patients, to you for to use that
You
machine?
could do it on the spine, but I don't really like doing it on the spine.
You
Okay.
use it
More
more for like extremities, more for like
Yeah.
plantar, for like the feet, tendonitis of the
tendonitis,
shoulder,
elbow tendonitis.
elbow, like tennis
Even
elbow.
just like an annoying injury that like patient's been coming for a long time and like
Nothing's not getting
just
better.
annoying. This is still annoying me, Christina.
Like a bursitis.
It's not covered by, it might be covered by insurance on a medical doctor, but PT can't do it. PT Chiro. It's a out-of-pocket expense.
What do you do for knee pain, arthritis, knee pain, that kind of thing?
Well, a lot of problem is the strength of the muscle, right?
Quads and hamstring strengthening.
Okay, so you try to really compensate
that
the
joint a little bit, right? Because
Really
sometimes it's
support the
actually
joint
just when people are like, oh, my knee hurts after I've been standing for like 10 minutes. some of that is actually just muscle endurance. You just don't have the strength in your muscle to stand or walk for 10 minutes at a time.
Got to exercise, aerobic exercise.
I know. I mean, well, I have to say, I mean,
strengthening, too.
I think you're absolutely right. Exercise is critical. I mean, you see these people come in. I mean, they weigh a lot. You know, they have a huge belly. They have a center of gravity is totally
Shifted forward.
and putting strains and stresses that they're not.
So it's hard to exercise when you have those problems.
Yes. So it's like it's kind of.
But that's where these new drugs come in that help you lose weight.
Well, I think that's playing a big
but
role.
the problem with
now in our
those
society.
is you're losing all your muscle mass.
Right. So you got to be. So if you're on one of those Zepbounds or what is it? What's the other?
Manjaro, Ozempic,
all
those drugs.
Wegovy, they're very popular. They cause muscle wasting. Why do they cause muscle wasting?
I'm not sure. I mean, maybe they're going to come out with designer GLPs that will be less toxic, not toxic, but just like less affecting the muscle. I don't know. The mechanism.
That's the big thing that they're seeing now.
I'm not sure why the mechanism is such that these medicines cause muscle. It's called sarcopenia.
Sarcopenia. And once you go off them, do you get the muscle back? Is the question. And how long does that take?
Muscles can be built up.
You can build it back.
Rebuild it
They're
back
not just gonna. Hey, my quads are here.
Right.
But I think
So if you're on those medications, you should probably be on a muscular, a strengthening program, weight
you should be
training.
on doing some weights at
Just
the same time
especially
to
because you're
compensate.
losing fat so quickly. Skin, your skin is hanging, all that stuff.
Yeah, no, you should definitely probably be working out, still be lifting
Those
weights.
plastic surgeons love these medicines because everyone's coming in sagging now because they lost all this weight. They have
They got to tighten their.
They have to tighten their neck. They
tummy
have to
tuck.
tighten their stomachs.
Everybody wants everything tightened.
Yeah,
Yeah, that's the way of the
It's
future.
the way of the world.
that's right. So, do you do just adults or do you do pediatrics too as well?
I don't do like early intervention torticollis pediatrics. I don't really focus on that. I feel more comfortable setting that out to like a specialist.
It's a pretty
pediatric
rare thing
specialist.
anyway.
Well, yes and no. Torticollis is much more popular now. I think because we know what it is and we know about it, and babies are laying on their backs now, right? When I was born, my mom had me on my stomach. No one had torticollis.
Is that the rule now for babies? They have to be on their backs when they're born because they're afraid of SIDS? Or they're
Back
afraid of-
best? Yep.
So that's going to prevent SIDS.
It'll
Like
prevent SIDS, but you'll have a crooked neck.
You have a
so.
crooked neck.
Well, I'd rather have the crooked neck than the SIDS, but
So that's really just tightness in the SCM.
It's got to stretch out the sternocleidomastoid muscle.
Yeah. So my son would have had a hint of it if I wasn't. Like
You were on top of him,
I was on top of it.
constantly turning his neck back and forth. So that's the new recommendation: sleep on your back as an infant.
Yep.
I don't remember what it was when I'm.
and then turn
You were
the
definitely on
kid's
your
neck.
stomach.
I was on my stomach.
No, but turn the neck.
I'm still on my
the same
stomach
time?
sleeper.
When they sleep on the back, you're supposed to be turning their neck.
Well, yeah. I mean, they should be laying. I mean, they'll ultimately end up to one side.
And that's what caused the torticollis.
Correct.
That's why you want to
exactly.
adjust that. And put them
so
centered.
I'll give like my son. I gave him like a little tilt. So I
We
forced
should invent
him
a little
to one
pillow for infants.
That'd be
prevent
They got it already. They got.
It's
You
already
name it, they
done.
got everything.
It's already done.
I'm sure
They got it.
Babies R Us has everything like that, right?
Does that store still exist?
I don't know. I haven't been
Bye bye baby's gone now.
They're all gone.
Why? Because
Amazon.
you buy online.
Everything's buying online.
But you like it.
Listen, as a recent mom, right? I don't know how moms didn't have Amazon or curbside pickup or delivery
We went and
straight to your door.
We shopped.
We did it the
I
old-fashioned
know.
way.
We had our shopping cart. We went into
It was
Babies
much
R
easier
Us.
for me during
Malls were busy when I was a kid. Now the malls are empty.
To get
I
my
was
diapers
just in the
delivered.
mall today. I couldn't believe it.
It's empty.
No, it's fabulous.
Which mall did you go to? Roosevelt?
Roosevelt Field. The stores are incredible.
Have you been
now.
to the Source Mall? It's like a big giant adventure park.
Oh,
really?
no, I haven't been
They
there.
got, like,
Is that where Dave and
pickleball,
Buster's is?
Fencing. Yeah.
Oh, interesting.
Yeah, they, used to have,
laser
they used to have a rainforest cafe there. It was like
remember
a
that.
go-to place.
I remember.
Yeah, it was really nice.
My God, I went to the one at Disney. Oh my God.
Yeah, there's a lot of new things around here that are quite good.
But I'll treat kids, I would say like 5 and up, general ortho injuries, stuff like
Okay.
that. But the true pediatric stuff, I will send out to a specialist. As a mom, I know what to do because I have kids, but I just don't feel comfortable doing it for someone else's child because parents can get a little.
So is that an additional training for physical therapists to do like infants and babies
Yeah.
for torticollis? And-
Yeah.
I guess you could really hurt some
You
kid
could.
doing that.
You could, yeah.
You
And like
overdo it.
you have vestibular therapy, which is another specialty. Pelvic floor is another specialty.
That's a big deal now, pelvic floor. As the
floor,
population
yeah.
ages for women, yeah.
Yeah.
It's a big deal.
And even like young women after like just having children.
Childbirth.
Is totally different.
So what does that do?
Pelvic floor.
It's important.
Well, you
Very important.
people are getting urinary incontinence and
That
things
is
like that.
pelvic pain.
Yeah.
You know, like you could have pain with intercourse too. So like, you know, not being able to like stand and hold.
So that's
Your pelvic floor is what
so-
holds you up.
yeah,
Really.
So,
Think
so,
about
so,
it.
so those are all specialties within physical therapy.
Yeah.
You do additional training for pelvic floor,
Yeah.
for vestibular, for infants.
Even neuro, like true
Oh,
neuro.
do you do vestibular?
I could do it. I don't love to do it. I could do like a basic simple one. I could like get the gist of whether
people
it's
get
true,
very, you know,
like
they-
BPPV or not.
It's a very
but-
Do you do the
crazy
Apley?
thing.
It's called the Apley maneuver.
Apley
I remember
maneuver.
that from medical
Down,
school.
you
Yeah.
turn 'em
I don't know
over.
much about it other than the fact that every so often I have a patient that needs vestibular physical therapy.
And some places have like the goggles. You watch the eyes. You know, I don't do that. I
There are some places that specialize just in vestibular.
There,
Correct,
there,
yeah.
there are, yeah.
So if it's like a true small niche, like I will refer out for that because that patient deserves to get the care that they need,
Right, but
not
you-
me saying, oh, like I could try and do it.
So look, so obviously there's a million specialties, but for our purpose is spine, post-operative spine, pre-operative spine. You know, those are the things we're going to be, you know, sending you mostly. For him, he's going to send you all kinds of orthopedic things too. But for me, it would just be necks and backs, basically. Patients with pain down their legs, pain down their arms, you know. What is the reason for this pain? I don't know all the time, but sometimes you hope that the pain goes away as fast as it comes.
Well,
comes
sometimes
around.
people will have that pain that radiates down to their arm or leg, and their MRI is negative.
I have had
Does not
plenty of
show. Does
patients-
not show a disc. Does not show.
or
Does
they
not
have
show
a
anything.
disc on one side and their pain's on the opposite
Yeah,
side.
it's
I
Well,
always
that's
love
my
that.
favorite. I have a disc on the right side, but why does my left arm hurt?
That's when you try to really treat that patient conservatively and don't send him for surgery at that point because
Yeah.
doesn't make sense, you know.
Well, I feel like because I don't rely on imaging, because I don't always have it, like I really just listen to what they say and I just
Sure, that's the best way to be.
follow with my hands. Like that's really my biggest diagnosis is what I feel and what they're telling me. Because
plus-
then not everything is always by the book, especially in today's day and age. I feel like, you know, anything is possible.
We used to have an anatomy professor in medical school, Dr. Moss, who would say, "Not every patient's body read the book."
Yeah.
Because, you know, in anatomy, sometimes there's abnormalities, there's differences
Oh my God, all the time.
from the textbook and what you have in your cadaver. So
And people just, you know, say, well, why did that person have this result and I'm not, you know, or I'm not getting it?
Yeah, that's my
Everybody's
favorite. Well, my
different.
friend had this. Well, that's your friend.
well more to
right.
the point though,
That's your friend.
the fact
It's
that
not
you're,
related to you.
the fact that you're treating their symptoms, they're going to come back to you.
Right.
know?
You have to treat the
Because
problem.
otherwise, they're not going to be like, yeah, I went to this physical therapist and they didn't do anything for me, and you know,
I guess
couple
some
times they'll
spillover,
go, but they're
though.
not
I guess
gonna
some
wanna come back.
spillover. Some
But I
of
wanna
these
come back.
patients
They'll-
are like,
they'll go
do
elsewhere."
You just do this.
How often do you like to see patients if they have, like, let's say post-operative for a basic spine operation? Like, what is generally
Say like
the
2 or
course?
3 times a week,
yeah.
2-3 times a week if they can get
if they could get there. Right?
yeah. You have trouble a lot.
And then pending insurance. So that's the other problem.
You have
You don't make house calls.
Only for specific people.
but you
Only
have,
for her husband.
but do you ever have like problems?
He's the worst patient.
what,
Love
That's
him
always the
very
way it
much.
is.
what are your main problems of insurance do you have, you know, with patients?
Authorization.
Authorization to get physical
authorizing
therapy?
like 5 visits after a spine surgery. What am I going to do with that?
Right. So how do you fight that? Do you have a person to help you fight that? Or do you,
I'm the person.
You're looking at her.
So
I'm the person.
So you have a person.
Get it.
You don't have that person to fight for you. You have to
I
fight
had a
yourself.
patient came to me with a total shoulder one time. Insurance authorized 12 visits and another 12 visits and said that he's done. He could do exercises at home. I said, I have a question for you. If this was your mother, how would you feel if they only got 24 visits for a total shoulder replacement?
And what'd they say?
So 24 visits.
Sorry, ma'am, I can't answer that question.
How long would that be? That would be like a course of, let's see, 2 to 3 times a week. That'd be like for like
2 months.
2 months. So 2 months is kind of not enough time for.
Not a lot.
For a shoulder joint?
I don't have much experience with that because I don't do those things.
No.
But
No.
okay.
They try to cut as much as they can.
Yeah, of course.
They're saving money that way.
Yeah, and then, you have to justify your documentation, which is fine. I get that. But not everything could be cured with just exercises at home.
But
No, I agree. You always can do more at a facility with a physical therapist.
Hands-
and you need somebody,
eyes.
yeah.
They can always stretch
you could tell
better.
the patient to do whatever home exercise program. Who knows if they're doing it correctly at home? If they're doing it incorrectly, they could actually hurt themselves even more.
This is like akin to like these medical kits they sell on TV.
I saw that today.
With basically all these, all you need basically
We have
to survive.
we have penicillin in there.
You might be treating something
Half the
totally
world is
in
allergic to
need
penicillin.
of another medical, a course, and you're sitting there treating at home. You have no idea what you're doing. It's crazy. So yeah, I agree. I think it's better to try to
Everyone's
get
a
in
doctor
there
today. Come on.
Medicare is pretty good though, right? But even
right.
Medicare, there are limits.
Yeah, they have their dollar amount limit, but you can go a little bit.
What about no
past
fault
it
and
just-
workman's comp?
No fault. Workers' comp, you need authorization.
You have to get authorization. That's
No
true.
fault is great as long as you arbitrate.
Yeah.
If you don't arbitrate, then
Yeah, I find that
cut
no
off, you
fault's
cut
the least difficult patients to get things going for them.
Because you don't need authorization.
Right, exactly. You
right.
just-
You just have to worry about their policy. Once their policy is exhausted, then obviously that's it. Treatment is done. But if you arbitrate, you're okay,
right.
Yeah.
which we do. So
So what do you like to see in patients after surgery? In your experience, what do you like to see as ways of saying, maybe I'm done with the patient? I mean, is it pain? Is it just functionality, mobility, like all the above?
pain, functionality, and ultimately how they feel doing their day-to-day activities.
Right.
That's it. That is what the goal is to get them back to their prior level of function, to get them back doing the things that they wanted to do. And if, guess what, sitting and reading the newspaper for 25 minutes was their goal, so be it.
Do you have a helper or somebody else in the office?
Like,
with
we'll
you?
have an aide.
An aide.
We have an aide.
When I was a resident, one of my mentors, Howard Rosen, used to say,
Didn't he just retire?
he passed away.
Oh.
That's really retiring.
It's been a while. He was a very special doctor. He was one of the first doctors to fix ankle fractures in the 1970s with plates and screws, which is now the standard of care. But at that time, he was a little bit of a cowboy. And he went to Switzerland. He learned how to do it. And he used to tell us, a good surgery can be ruined by a bad physical therapist. A bad surgery can be helped by a good physical therapist. But really, what you want ideally is a good surgeon and a good physical therapist. And it's key to have a really good therapist who knows what they're doing, who gets the patient their range of motion back, their pain level at a decent level, and ultimately get them to be functional.
Yeah. I mean, half
all
the
about.
time just listening to what the patient says, which a lot of people don't do.
What do you find is the common sort of thread or complaints that patients say after, what have you heard?
After what?
Just anything, surgery or stuff. Do you hear are they bad mouthing the surgeon or the
Not usually.
husband? I mean, what?
It's usually the spouse.
Not helping me enough.
You become a physical when you're a physical therapist. The good ones are kind of like psychologists also.
Oh, I have heard.
Because you start becoming, you see them 3 times a week.
Spend time with them.
becoming their friend.
They
You
tell me
spend
their
more
deepest,
time-
darkest secrets.
Oh yeah, you know everything. She's like the key.
Oh yeah, you know everything, and sometimes
And they
decisions
feel
are made.
comfortable with you. And
Yeah.
ultimately, that's what you want, right? You want the patient to be able to feel vulnerable around you because they are.
Right. We don't have that luxury because we're seeing them once every 4 to 6 weeks.
Right, exactly.
There's a little more of a distance between the physician and the patient.
It's always the case.
And they can always be a little more professional with you
Yeah.
guys than they are with me.
Yeah, they'll tell you their deepest secret. For us, not so often.
Well, that's good because then you're the kind of in a way a gatekeeper for problems that need to be addressed.
Well, she can also identify psychopathology in people and.
Right, say hey, I don't know.
I don't know. You better be careful operating this one.
Right, exactly. You can screen out the patients for us.
Yeah, right? Yeah.
That's another advantage of having a physical therapist close by.
So this is great. So I
It's
now
good to have one in your corner.
I always rarely do I ever get notes back from the physical therapist.
Really? I get them all the time.
I get
Medicare, you need a plan of care signed every 30 days.
I get nothing back. I don't know. I never see anything. I just
Your underlings must be dealing with it because I'm sure your fax machine is filled with their notes.
I know his is.
Mine is.
Well, I am definitely I definitely like to communicate with the various people, ancillary people I deal with, the physical therapist, the pain management. Those are very
Because
important.
there's not every surgery is the same. Some required extra time. Some required other other things to be done. You know, you open them up for one thing and you're doing something else. And like that needs to be communicated to all disciplinaries, you know,
I like
not
to,
just
I like to
necessarily
write a
PT.
note and explain, what the patient's problem is, not just check off like, do this, do that,
What do you mean?
just like a consult note, when we
You want a consult from the physical therapist?
No,
or
I like
when
to-
you write your referral to the physical therapist. You write
to
a consult.
refer to the physical therapist, what needs to be addressed, because it helps them, focus in,
You don't just write the diagnosis. You write actually.
Yeah, lumbago. That really works.
Okay, well, lumbago is not a neurosurgical diagnosis.
my
Right, that's an orthopedic
That's my
diagnosis.
No, it's not even. Okay,
Is it even a code anymore?
it's a code. Lumbago just means
still a
low
code?
back
It's a
pain.
code from the 60s that
it's
Dr.
a fancy word for lower back
Bernstein-
pain.
I didn't know if they converted it to the
Lumbago.
ICD-10.
Lumbago.
My lumbago's acting up.
Oh, my favorite is I have sciatica in the front of my legs. I'm
Right.
like, oh, you
That's
do?
My sciatica.
Wow, that is really impressive.
Yeah, it's
Always
garbage
educate a
bag
patient
term.
to tell them that the sciatic nerve is not actually being compressed.
Well, that's another thing. Like some patients just don't understand the
They just think
human body.
leg
There's
pain is
anatomy.
sciatica, whether it's in the front or the back.
Right.
How do you
And they
differentiate
just don't
between
understand.
piriformis syndrome and real disc pathology causing nerve recompression? This is my big question.
Usually with flexion or extension of the spine.
Okay, so
Right. So you're, or even like side bending of the spine. So you're moving the spine to see if you're reproducing those symptoms, right? Because with piriformis syndrome, not always, but usually, the spine is not the problem.
right.
Right. It's not.
So if we're moving the spine and those symptoms are reproducing, even though you have pain in this butt area over here, it's not always just piriformis. It actually could be a disc dysfunction.
Right.
So that's usually how I differentiate between the two.
That's very important, I think, a lot of times, especially if the patient doesn't have an MRI, coming in, initially.
Yeah.
But those are tough problems.
And like even just in general, like people have like stubborn back pain, and like my first question is like, have you had any unexplained weight loss? Do you have night sweats? Do you feel any other funky things going on? Because like, how many times do you see?
Yeah, you don't want to miss a malignancy or an infection or something
Right,
really bad
exactly.
going on.
Absolutely.
So
that would be
that's
bad.
another
It's
reason
very
I
good
guess
that
for
you go
differential
through
diagnosis.
sort of a review of systems of patients.
You have to, because not everything may be musculoskeletal. Like that's what I specialize in, so I know that. I don't know everything else. I shouldn't have to, but you do, because this is what the world we live in.
Yeah, it's
now
very
people
smart.
are coming to me, so I have to make sure that I am checking off all of these other boxes. And if I do hear something funky, I'm like, hey, listen, like I think you need to go see at least your primary. Go get a blood workup. See what comes back. If it's nothing, then you have a CBC and you see what's going on. Maybe you have a cholesterol problem and you figured it out.
Sure.
But I'd rather just clear that and check that off to make sure that I'm not missing anything.
Right.
Because that could go like in a
one of the
different
early
direction.
symptoms of pancreatic cancer is back pain.
Right.
And stomach pain.
Stomach pain. You don't want to, and a lot of times it's missed, and by the time it's diagnosed, it's already spread, and it's too late, and
That's right.
it's a terrible thing. So I think
Yeah, back pain, like digestional issues.
they get depression because they're
and
like
then
having this pain.
like
nobody knows where it's
diabetes
coming
too
from.
is another big
Yeah.
thing, which
I agree.
unfortunately
There's
at the age that it
definitely
comes out,
Other
it's-
reasons for back pain besides the spine.
It's not always spinal.
That's the point.
yeah.
Yeah.
So
I mean, even shoulder pain, like you could have a gallbladder issue referred to your shoulder.
that's right.
Absolutely.
So yeah, look, it
Aneurysm.
sounds like you really, have a great sense of,
I had a couple people
systems.
that had like they were in a car accident, had an MRI, and like found an aneurysm, so it was like an incidental finding.
Yeah.
I had
A
a
lot
patient
of
that had a
incidental
tumor
findings.
in her thoracic spine.
Yeah.
She was complaining of pain in her
Or a
knees.
car accident.
Nothing I did fixed it. Nothing I did made it better. Got a thoracic MRI, found a tumor, removed the tumor.
There you
No
go.
more knee pain.
Knee pain.
Yeah. So, sometimes you think, oh, I got into this
Crazy.
accident, it's a terrible thing, and it's the worst thing that ever happened. And then on an MRI, incidental MRI, they'll see a tumor in their kidney.
Yeah.
Yeah.
Or
And like then ultimately you know why this happened, right?
yeah. So sometimes we think
It's
things are-
unfortunate that it did happen, but it could have saved your life. So
Yeah.
Well,
I believe things happen for a reason.
100%.
Well, on that note, I'm going to say I think we're out of time. Wow, it went so fast. We could have talked for hours more about
That
stuff.
was awesome.
But thank you so much,
My life is a
Christina.
podcast every day.
That's terrific.
We're living in a podcast.
Well, now you're going to be even more, basically known after this.
This will be cool.
You should be.
I'm gonna stop by your office one day. The one in
You should
he's got
stop by.
he's got an office in.
Rockville Center is our main South.
Is that your main office?
That's our main
You guys have one in
national
Lake
office.
Success too, right?
We still have an office, a big
Lake
office in Lake
Success
Success.
what is it? Right by the LIE, right?
It's right by
Northern State?
right off the LIE in Northern State, right there, right near
You're closest to
the
the
quadrangle, the Lake Success quadrangle, near that.
by like Optum over there, or before that?
Very close to, but it's before Optum.
By that big deal, but that big building that
Yes,
they just built
that dealer,
across the street.
whatever,
Yeah. Where they used to have the
thing.
car. And,
What does that thing do?
I don't know.
Building. I have no idea. But anyway,
Is that machine where you can buy cars and?
I thought it was like some
It's
sort
Carvana.
That's Carvana.
Big tower.
I was looking at that thing.
That's pretty
today.
cool. That Carvana thing.
Does it really work?
You ever
They
seen
put
a Porsche
coin
tower
on
in
it?
Miami?
They have the same thing.
You have to have a Porsche to live there.
You have a Porsche
Yeah,
to live in
and
the
the-
Porsche Tower.
Yes, and
You live
the
there.
Oh yeah, well,
elevator will take you up like you have a garage in your.
that's
We don't want any
Crazy.
non-Porsche people in our building.
Crazy.
Well, the thing is now all these brands they do other things. They have resorts, they have hotels, and
I mean, they got to keep up with
I
the
think
times.
Ferrari makes more money from their gear than they do from the actual cars. Their hats.
You know you have to qualify to buy a Ferrari?
He qualified.
all right. Listen,
He's qualified.
I only know this because my
personal
husband
life-
tells me this stuff.
this could be
This is not on the pod.
This could be all edited.
could
Well,
be
no,
on the
we
pod.
haven't finished our conclusion.
Oh.
Yeah, could be on the pod.
Oh, I thought we were done with the pod.
Me too.
Well, I want to say thank you formally, Christina,
You're
for
welcome.
coming in here today.
Thank
It's
you for having me.
wonderful For meeting you, and I look forward to referring patients to you and basically
No,
seeing
Christina's
how
a
you do with
delight,
them.
and her husband is really cool.
Yeah, he met him.
Yeah, really nice,
great.
good family. She's got 2 kids.
Yeah.
Working there in Dr. Obedian's empire there, Island Spine and Sports.
Yeah, it's
great,
a nice
great
place
location.
to be. 81 North is fun.
Yeah, it's fun. It's a good place.
It's good. There's always
Very
food
good.
there. There's always food. Always
Yeah, I
stuff
smell
going
it.
on.
I smell it from the upstairs.
You're always
people,
invited.
people are always popping in there and working
We have
there.
a lot of
Yeah.
a lot of very happy patients who
very welcoming atmosphere, I must
Yeah,
say.
and that's a lot of patients see that. That's a big thing.
Oh, I think so too. I'm a patient of his. I get knee injections.
Atmosphere,
Something.
environment, ambiance, the way you see me here is the way I am,
Yeah.
like in the office. I don't change. I am who I am all the time, and I think that says a little bit of why sometimes a patient enjoys coming.
How often are you in Hicksville versus Great?
I'm in Hicksville right now twice a week. I'm in Great Neck 3 days a week.
Oh, really?
Patients love her. They love her. She gives them a good workout, and
I'm a little loud, but
she's a little, it's
Well, I think you have.
They-
Sometimes
well,
people
well,
don't hear
loud
what you're
Italian.
saying.
What do
they
you
like
want?
the, they like the results. They're feeling better after you have a treatment.
That's
That's the whole point.
That's the important part.
Well, I'm very happy that we got to meet you and have
Yeah, this is gonna
come
be
on as a
great.
guest today. It was wonderful. Thank you so
Whenever you
much.
need, let me know.
And now you know that she's a doctor.
And you're a doctor. That's great. Are you actually a PhD doctor?
No,
They
no.
just call you a
I'm DBT.
DBT,
Doctor of physical therapy.
doctor of physical therapy.
Like a chiro, same exact.
Same thing, but
Chiropractor is also
Chiro-
a doctor.
Chiro can prescribe for MRI and X-ray.
not everyone that I've met been able to do stuff like that. Some chiropractors can't.
Well, it depends on the insurance, I think.
yeah, some of the insurances
well,
dictate.
like no fault comp, you could do it, but you're going to need authorization.
And also, chiropractors
all-
can't usually do extremities. They can do like neck and
Correct.
spine.
If they feel it's coming from the shoulder, you can kind of justify.
A lot of times,
like,
doctors,
shoulder dip.
chiropractors will send the patients to me just to get the MRI sometimes, to see the patient get the MRI.
Yeah.
But it depends, like you said, on insurance. So,
If everyone would just like work together, I think the medical field would be
oh, really?
different.
Yeah, wouldn't that be nice? Wouldn't it be? Everybody's on their own little thing,
Even
own
within the
little
world of
island.
even within the world of orthopedics and neurosurgery, we don't get along.
It
with
all has to do with
each other.
communication.
There's competition.
It's
Like Dr. Sansi was saying, we're living in a sea of sharks.
I always feel that way. I mean, we were swimming with sharks in Nassau County, but yet we've been able to swim for at least for me and him, I've been 28 years here.